Afternoon, everyone. Thank you for coming to my presentation. My name is Daniel Nguyen, and the title of my thesis is Deep Learning in the Derivation of Predictive Outcomes Models for Radiotherapy Toxicity. So to quickly break this down, the plan is to use deep learning, which falls under machine learning, which is a type of program which learns by itself without being programmed explicitly. And this is typically used in state-of-the-art image recognition. And so the idea is we're going to take dose distributions from radiotherapy, and more specifically from radar clinical trials for prostate cancer, in combination with toxicity outcomes for patients from the treatment. So toxicity is just the irradiation of healthy cells that go on to cause side effects in the healthy tissues, which can cause things such as urine in the blood or burning sensation during urination. So prostate cancer is actually has the highest incidence rate in Australian men at 14.4% in 2015, with 17,700 new incidences in 2018 in Australia. The major factors which affect prostate cancer, the onset of prostate cancer, is age, race and ethnicity, and family history. But more importantly, and this is a good thing, the 5-year survival rate for prostate cancer post-diagnosis is actually 95%. So 95% of those patients that are diagnosed with prostate cancer survive the 5 years. But toxicities can include, as I stated before, dysuria, which is burning during urination, and hematuria, which is blood in the urine. So in order to treat a patient with prostate cancer, we first have to get a treatment plan. So in order to obtain a treatment plan, we first need a CT scan. And from the CT scan, we want to delineate the tumor volume or the treatment volume. We then add some margins for internal, external motion and setup variations to get a treatment volume for planning. And then we also contour organs at risk, such as the bladder and the rectum. And then these two are combined in combination with the prescribed dose to the tumor, as well as dose constraints, to produce these dose distributions, which are basically just the energy absorbed per unit mass for a particular position within the patient's body. So moving on to deep learning, the first one I'm talking about is artificial neural networks. So we basically have these large interconnected network of neurons, which have these connections between them which are weighted. And so what the machine does is it runs through an algorithm which updates these weights according to the data that is given, so the outcomes and the input data. And as such, that's how it learns. So there are hyperparameters, which are just parameters that affect how the model will learn. And these can include the number of neurons per layer or the number of layers. Now moving on to convolutional neural networks. Convolutional neural networks are similar to artificial neural networks, except they have an additional convolutional layers. So convolutional layers apply convolutions, as you may know, which result in a filtered map, which is the output for this convolutional layer. So these filtered maps are basically, we take a filter size grid of, for example, 3 by 3, and then those 9 pixels within that region are then connected to one neuron in the next layer. So it's a form of using 2-dimensional and 3-dimensional input data in these artificial neural networks to reduce the dimensions and improve parameter model performance. Max pooling layers are further added to reduce number of parameters, which you can see in the example is after the convolutional layer, to further reduce, to improve on any overfitting that may occur. Furthermore, the filtered maps are flattened into 1D-dimensional vectors, and then this is fed into a fully connected layer, such as in the artificial neural networks. So, problems in machine learning. We have 3 main problems that need to be addressed in practically every machine learning problem. And the first is the data scarcity. So a lack of data can greatly reduce the model's performance. For example, state-of-the-art image recognition utilized millions of images of dogs, cats, trains, all of that, in order to get high performance. So in order to reduce this problem, we need to introduce some sort of data augmentation or increasing the size of the data set. The second problem is data imbalance. So particularly in medical data, where we want to reduce toxicity as much as possible, the number of patients with the toxicity outcome is much lower. And so we need to apply some oversampling and undersampling in order to balance the two data sets, the two classes. And the last one is curse of dimensionality. So we need, so for example, a three-dimensional dose distribution has 600,000 or so voxels. And so each voxel is considered a dimension in this case. And so the distances between the data, when the dimensions are this high, is much, much larger. And as a result, it makes it much more difficult for the models to be trained. So from the literature, Yahe et al. Did a paper on the toxicity versus bladder surface dose maps. And they found that dysuria was strongly associated with the dose to the anterior inferior area of the bladder, as well as hematuria being correlated to the anterior inferior and posterior superior regions. The same Yahe et al. In 2016 also found that using statistical methods on extracted features from the same radar trial data that I'm using, found a performance metric of 0.649 on their best models. So 1 is a perfect classifier and 0.5 is the equivalent of a random classifier, so that's not too bad. Valdez and Interin in 2018 commented on a transfer learning paper by Zen et al. On rectum toxicity, and their conclusions were that data augmentations for medical data in particular are most likely inappropriate. Well, translations of rotation, are most likely inappropriate due to the fact that the toxicities are most likely resulting from biological, underlying biology, and also that the data set size of 42 is too small to confidently say that they have a good model performance. So the project aim is to be able to, of course, produce a predictive model which can accurately and confidently classify toxicity outcomes. And this is done through the following. 1, identify suitable data augmentation techniques to increase the size of the data. 2, identify and test appropriate dimensionality reductions. 3, techniques, 3, compare different neural network architectures from the above and find the best models for those. And then 4, visualize these models and examine the regions of greatest importance. So the materials I used were a computer supplied by myself, which had an NVIDIA GTX 1660. This was used in alongside Python, which allowed me to take advantage of the GPU's faster computing powers, as well as these Python packages, most importantly TensorFlow, Keras, and Talos, which allowed me to build the neural network models, as well as the hyperparameter search, which was required. MATLAB was required, but I did not use these in the final results, unfortunately. So the radar trial itself, this is what we got the dose distributions from. The toxicity outcomes came from a self-assessment from the patients using this questionnaire, and these were taken up to 10 years after the patient's treatment. The toxicity was graded from 0 to 4, with 0 being no toxicity at all and 4 being the most extreme. And for dysuria in particular, there's about 600 patients with only about 13.5% with toxicity. So our data scarcity problems is very prominent. We don't have enough data. Data imbalance is definitely there. There's only 13.5%, as well as our dose distribution is extremely large, 166 by 125 by 32 voxels. So we're going to have to apply dimensionality techniques to that. So the data preparation. So there were 3 different dose distributions provided to me by Angel Kennedy. And the first is the VO27, and the second is SO33. So these two are the 3-dimensional data sets, and there's a slight difference between the two. The first here, the VO27, was first cropped for all the CT images, and then an image registration was applied, which refers to putting all the images onto the same spatial resolution, onto the same spatial coordinates. So it was cropped first before image registration, whereas in SO33, the images, the full CT scans with image were registered together first, and then later on were cropped to a focus region. So this may result in a greater importance in the focused, in the bladder and the rectum and the prostate, which were what was the focus of the croppings. Furthermore, to reduce dimensionality, downsampling was used 1 and 2, and then data augmentation, B-spline data augmentation was also used to increase the size of the data. So for each of the three-dimensional dose distributions, I created 2 different architectures, three-dimensional convolutional neural network architectures, and these were compared together. And in terms of the bladder surface dose maps, so these were provided by Angel Kennedy as well, and they are 2 dimensions, of course the dose to the surface on the bladder, and these were inserted into a 2-dimensional convolutional neural network. In addition to this, the 3-dimensional dose distributions were further reduced in dimensionality using a PCA, which is principal component analysis, which converts them into 1-dimensional dose data, and then this was fed into a 1-dimensional artificial neural network to see how it goes. So in total, I had 7 types of models to train. So firstly, having a look at the data augmentation. So the aim was just to have a slight difference in the original and a deformed, just a slight deformation in the two. So on the right, you can't really tell, but where it's white is the difference between the two, basically, on the very, very third image. So the B-spline was also provided by Angel Kennedy, thank you. Since registration uses deformations in the CT scans and dose distributions, it seemed to fit to use the same deformations or similar deformations in order to augment the data. And so each image was deformed 10 times, and so we increased the data set by a factor of 10. So this is the neural network architectures for the 3-dimensional convolutional models. I'm not going to go much into detail with it, but basically they had 9 hyperparameters for both of them. The main difference between the two is that the first one has a variable number of convolutional layers, whereas the second does not. And that was mostly just to see what the effects of this had on the models. And we also have the 2D and the 1D architectures for the bladder surface dose maps and the principal component analysis data. The 1D neural network is just very simple, which is fully connected layers with a variable number of hidden layers. And the 2-dimensional model was very similar to the first architecture for 3 dimensions, but just a lower dimension. So a variable number of convolutional layers as well as hidden layers. So in order to find the best models, we need to train and predict thousands of models to find the best ones. And Talos is a hyperparameter optimization package you can use in combination with Python in order to search the hyperparameter space to find the best hyperparameters. So this allows us to manually select our values for the hyperparameter space. So for example, hidden layers we can have from 0 to 10, for example. And then the package will automatically pick out the permutations by itself, do the training, and then do some predictions. So firstly, some results. So this is for the VO27 Architecture 1 results. This is just a slice of the hyperparameter results. So we got hidden layers, neurons per layer, convolutional layers, number of filters for each layer. And so the main thing to take away from this is that during training, it does really well, but during validation, extremely poorly, so we have lots of overfitting. So it just overfits on our training data. So just to visualize it a bit better, in blue we have the training data performance. So this is a Matthews correlation coefficient. So the higher it is, the better the performance. And then in orange and green, we have validation and test sets, which you can see are a lot lower. So for the rest of the training, we basically found the same results. Lots of overfitting, nothing really stood out well. So this is just from each architecture, the hyperparameter search for hidden layers. But you can see, so this top row here is for the training results, performance metrics, and that does extremely well. But once you go down to validation, all the performance metrics drop really quick. So the area under the curve is another performance metric that was used, and it's typically used in medical data, so I saw it fit to use it in here. So I picked out the best models with the best validation and test results, and these were what I found. So the highest performing model was from VO27 with architecture 1, with a validation of 0.63 and a test of 0.57, as well as the VO27 architecture 2, which had a validation of 0.62 and a test of 0.58. So perfect classification for the area under the curve is 1, and for the equivalent of a random classifier is 0.5. So you can imagine this is not so great. And this just visualizes what we have up there basically. Some of the results can jump quite high. So this one goes up to about 0.66. But what I found was that even though the validation results were really high, the actual training results were really low, or the test data results were really low. So it was just something that was lucky. So moving on, there's no big difference between the two architectures for the three-dimensional convolutional neural networks. So if we're comparing these two together, the results are really similar. So for VO27 and for SO33, the results are also pretty similar. And so there's no big difference there between the architectures. Something that was noted across the board was that VO27 performed slightly better than SO33. So if we have a look at these three here, for VO27, they're a decent amount better than the SO33. And that might be coming back to the registration approach and how we cropped it before applying image registration. So Yahia's study achieved an area under the curve of 0.649 on the exact same radar trial data. So we're not far off, but one thing that is important is that I didn't apply any cross-validation, which is a further means to have conclusive data, which is basically you train the data multiple times on different subsets of the data for the same architecture, and then we average the performance results. But unfortunately, I didn't do that, so the results aren't as good as they could be. So improvements for the models. So we could possibly use a direct registration process to augment the data instead of manually deforming the images. For example, instead of keeping the two data sets separate, so VO27 and SO33, I could crop the SO33 to have the exact same location and shape and dimensions as the VO27, and then combine the two into one full set of data instead of working on them separately as I did. More is refining the code and including cross-validation, of course, to make the results more conclusive. Testing other architectures, such as GooglyNet, which uses inception modules. These would introduce a greater diversity in the models. It would allow the models more freedom. And also possibly incorporate non-dosimetric features, such as age and morbidities using a voting classifier. So another thing I did was visualizing the models. So using GradCam, we can extract the gradients from backpropagation from the models itself to obtain areas that it deems important to predicting the outcomes. So in red, I've shown the regions of most importance. The gradients came out from 0 to 1, the pixel value from 0 to 1, and these reds, the red areas show above 0.6, so 1 being the most important. And I found that regions of most importance were the superior posterior region of the bladder, as well as the center of urethra from VO27 architecture 1. However, this contradicts Yahiya's study, which found that the greatest association between dysuria was with the anterior inferior region of the bladder, so slightly different ends. SO33 architecture 2 also found that there were regions of importance around the anterior region of the urethra. So overall, what this means is that these models are actually learning something, because what we expect from toxicities is that they are indeed related to the urethra and the bladder, and that's what the studies have found. So it is quite promising that these models are able to learn like this. But another thing is that these GradCam images were only produced for a few models due to code and time constraints. So I don't have GradCam images of all of them, so it would be good to improve on that and maybe average all the GradCam images across multiple models to get a better idea of what the model deems important. So furthermore, for future clinical applications, or for current clinical applications, there are none, because these models are very poor in terms of predicting the toxicity outcomes due to overfitting. What might improve the model performance, well, is likely to, is real data, real labeled data, an increase in the amount of real labeled data. But the problem with this is that it requires a clinical trial, it requires time for collection, because the toxicity outcomes, it takes 5 to 10 years to collect all of the outcomes, so it's quite difficult. And dose distributions are actually outdated, because these are based on conventional radiotherapy techniques, and at the moment we're using much more advanced techniques, cyberknife, proton therapy. So, yeah. So in conclusion, further studies need to be done for data augmentation and dimensionality reduction techniques, because the models are not performing as well as we would like. Overfitting was prominent in all models. The best model achieved an area under the curve of 0.63. The GradCam found the urethra and bladder to show importance to the dysuria toxicity outcome, and they're also a promising way to visualize the models. Thank you for listening. Any questions? Kelly.
So what made you decide to go for Python rather than MATLAB?
Yeah, so mostly just the amount of support that is found in Python. I was trying to look up three-dimensional convolutional neural networks just in MATLAB, and it's really hard to find any. And when you do find them, there's not a lot of support for them, or there's not a lot of users to provide feedback for the support. So it's a lot harder to use, as well as I would have had to code my own hyperparameter optimization tool instead of using Talos, which they provided it with, that came with Python. I found it on, yeah.
I'm not sure if I missed it before, but what was your split between your training?
Right, yeah, I didn't mention that.
Yeah.
It was, I believe it was 33% was split off for testing, and then for the remaining, it was, I believe, 50% for validation, and then during training, it automatically takes 20% out for validation during training. Yeah. Yeah.
I have a few questions.
Yes.
What is your selection criteria for the models, neural network models?
Yeah, so I couldn't really find much, especially for three-dimensional convolutional neural networks. So it was mostly based upon the successful two-dimensional ones. But then I wanted to increase the amount of freedom. So I started introducing like a variable number of convolutional layers and such. Yeah.
So like your accuracy is less than the Yaya's technique. Do you think there is anything special in the Yaya? Because from the literature you can find actually which are the 3D techniques, models which are working well. What Yaya did which you have not done, and you think
Yeah,
it
so
makes
they used feature extraction on the dose distributions. So they didn't actually plug the dose distributions into a model. I don't know too much about it, but I'm assuming the feature extraction reduces dimensions a lot better than what I've done, and so there's a lot less like noise in terms of the amount of inputs to the model.
But you also used a PCA for one.
Yeah, so that was just grabbing the dose distribution and giving it to a PCA, retaining about 90% variance. But using PCA kind of removes your spatial, a bit of your spatial dependence, which I think would make it poor. Although the PCA results aren't too bad, 0.6 and 0.6, but I believe that maybe PCA is not the best in terms of medical data, but yeah.
Okay, and do you think that actually, last question, do you think that actually your model may have a problem than actually your overfitting and all those things or data?
As in like the architecture is wrong, or?
Your
Yeah.
neural network model might not be a suitable one for
Yeah,
this training.
for sure.
For this problem.
For sure, I didn't try a large variety of neural network models, and so I definitely think that we could probably find a different architecture in general that would work better. Yeah, that definitely needs to be looked into, I think. Yeah.
How long does it take to predict an outcome once you put it into your model?
For predicting, it takes no time at all. It's mostly the training that takes a bit of time, because all the weights have to be updated and the parameters, and it iterates through the data like hundreds of times. So yeah.
Could you suggest any other architectures that might work better?
At the moment, not really, other than possibly trying some inception models which GooglyNet used. They used inception modules in their 2D image recognition, and yeah.
Yeah, it was a great work. It's quite brave.
Thank you.
It's not really been done before in this field. It's, I guess, exploratory what we're doing. So the way we did it was to register all the patients onto a common coordinate system.
Yeah.
We didn't really need to do that necessarily, did we? We could have just looked at each dose distribution like a cat and dog picture, like something completely separate, and classified them separately. Would that have been? Would have been there be an advantage to that, or was there an advantage to the way we did do it by registering them all into a common space?
I think there's an advantage in doing in registering it. Also, partly because all the body shapes would be different, and the way that affects the dose distribution. And so, like, the dose distribution for one patient might have a very high dose in a position that might be the bladder for another patient. So I think registering is a good idea, but it might be also a good idea to try it without registration.
Oh, just a comment on slide 25.
Sure.
You've got the correlation at the urethra, and that's for dysuria, isn't it?
Yeah, that's for dysuria.
That's pretty consistent with my results.
Yeah. Awesome. It's good to hear.
Otherwise you'd be wrong,
Thank you. Thank you very much.